only a Schirmer's test is done for assessing the level of dryness. What tests need to be done to evaluate which type of dryness it is?
So the most important test that needs to be done is called staining of the corneal surface. Usually the fluorescent dye is used to do that. So your dry eye specialist or your cornea specialist or your ophthalmologist should stain your eyes to see how severe the problem is, number one. The Schirmer's test, if done well, is quite informative, but the Schirmer's test is very unreliable and it can give variable results based on the external, the environment of the room that you're in. For example, if you're sitting directly under a fan or an air conditioner, your Schirmer's readings can be falsely low, and that can exaggerate the amount of dry eye you have. So we usually do use the Schirmer's test, but it is not very reliable unless you're doing it in the right way, which often it is not. So there are other objective tests. We typically call this a comprehensive dry eye evaluation. It consists of 3 tests, which are usually done on a machine on which you keep your chin, just like a slit lamp, and the machine takes some readings without any contact. These tests are called the tear meniscus height, the non-invasive tear breakup time, and meibography. Meibography is essentially infrared imaging of the meibomian glands. The non-invasive tear breakup time, or NITBUT, it measures how fast your tear film breaks up on the eye when you stare, when you don't blink. And your tear meniscus height essentially measures what is the height of the tear film in the eye. So these 3 tests are very, very important. They're objective, they are repeatable, and they're more reliable than the Schirmer's.
And talking of testing, then once you are diagnosed with any of the 2 dry eyes, are you supposed to go for regular checkups or follow-ups? Is there a protocol for that?
So patients with evaporative dry eyes, we first try to explain to them why this is happening, what they can do to reduce their symptoms and make them more functional. Like I said, blinking and warm compresses, etc. And then, using lubricants as and when needed. And if, 90% of the times this is enough, and evaporative dry eye patients, although, like I said, both conditions are chronic.
Right.
So it is, these problems don't completely go away, but if the patients with meibomian gland dysfunctions are taking care of these things, they are able to function well and keep their annoying symptoms at bay largely. And they don't need to come in and see the doctor all the time, only when they have some kind of a spike in inflammation or symptoms, etc., or something goes wrong. If these patients are not able to do these things, or despite doing all of these things, they are still symptomatic or still not able to function, then there are certain targeted therapies for the meibomian glands. So the very popular treatment for this is called the LVPEI. So the LVPEI, you basically lie down on your chair, and there are applicators which we put on the eyelids. And then basically it's a system where warm water flows in through those applicators, and it gives a little bit of pressure on the meibomian glands and this is essentially massage delivered in a very standardized way to the meibomian glands directly. There is also something called intense pulse light therapy. This is again borrowed for dermatology. Like I said, meibomian glands are modified sebaceous glands. So just IPL is essentially, there's a flash of very bright light that is given. Your eyes are of course closed. It stimulates the parasympathetic nerves in the skin that help in opening up these glands, both in the skin. So it was initially developed for acne, but it can also be used for meibomian gland dysfunction and evaporative dry eye. So that's for this part. And for aqueous tear deficiency, if things become, they do need to follow up with the doctor, both with their rheumatologist who are treating their underlying systemic condition and with the ophthalmologist. I would say every 3 to 6 months.